Welcome to Recovery Empowered Language. I am Patti Heffernan. My pronouns are she, her, hers. We do training and consulting and technical assistance for substance use recovery oriented systems of care. That's just a fancy way of saying we tell governments what evidence-based practices are, and sometimes they listen and sometimes they don't. We also try to help our fellow recovery community organizations and collaborate with other technical assistance and training agencies such as CCAR. And these will be hours that are approved to count towards your RCP. So there's really no such thing as a safe space. While we always do our best to accommodate and make people feel comfortable, there's always a chance for getting hurt because we are all human after all. So instead, what I like to focus on is creating a courageous space because those spaces is where the most growth happens. So we can go ahead, you can either come off mute or you can pop it in the chat. What are some things that we need to have a courageous space? Like we could feel like we can speak up, ask questions, etc.
Respect.
Right? Respect. I like it.
Vulnerability.
Vulnerability. I like that one. See in the chat, no judgment. Oh, and to the question about the slides, yes. I believe we are sending these out. Some patience, empathy, grace. Yep. Awesome. Others. Vegas, what's said in Vegas stays in Vegas. Well, I hope you take what's here, take it with you. Kindness, empathy, consideration for others, try to remove some fear. Yeah. No talking over others. Yes, that's a very good one. This is the reason why we all know that the hand raising function works, so that especially with the delay with Zoom, we're not all, talking over each other and go, oh, no, you go ahead and get all. Well, I would be Midwest. I'm out here in the Wisconsin being Midwest nice. So, and yeah, being genuine. I like that. Asking questions in good faith. I like that one too. Respect different lived experiences. Yep. Being open-minded. Yes. Those are all great things for learning and setting up the space. Awesome. Anything else? Knowing the difference between dehumanization and disagreement. Love that one. Oh, this is going to be a great group today. Yes. So I like the grow shrink. If you're somebody who tends to be real dominating and really, really participate a lot in trainings, that's awesome. We love hearing from you, but maybe shrink it down a little bit. And if you are somebody who tends to be real quiet, maybe stretch a little bit, raise your hand a little bit more often, because remember, this is a stretching place. And yeah, we're going to use recovery language and we're going to learn more about it. And then the other thing is I like to say to lean in with curiosity. If I am having a reaction to something that's being said, instead of trying to shut down the thing that I am reacting to, I am going to lean in with curiosity as to why am I having that reaction? What am I feeling threatened about? What am I feeling worried about? What do I need to be brave or courageous about in this moment? All right. These are some really great ones. I'm looking forward to this as we get started. Okay. All right, so your learning objectives for today. We're going to explain how recovery language is commonly used and treated, and recovery has negatively shaped the public perception. We're going to identify terminology that has contributed to most stigma and worsening stigma, and some alternative terminology. I'm also, as you know, language is like any language continues to grow. I mean, like my kids keep walking around using this word Riz. I have no idea what it means. I'm dating myself a little bit there. But language grows and changes. So, we want to add more language. So if there's new terminology, we absolutely welcome that here. We want to hear it and we'll talk about it. And whether or not we as individuals, practitioners, providers, coaches, peers want to adopt it. And then we're going to cite some specific strategies that can be used within their programs and in the community to encourage more person-centered mindset about addiction and recovery. We're going to kind of try to break this down into 3 parts. Today is going to be focused mainly on the one-to-one stigmatizing language and how to, when we're working, with our people that we're either providing peer services for or we're a provider for. But then we're going to talk about it in the workplace and talk about it in the media. Those are like the 3 main different categories and how all of these objectives are going to apply to those. Tomorrow's going to be much more focused on workplace and in the media at large. Today is going to be much more focused on one-to-one and individual terminology. All right, so this is going to be our first little activity pretty early on here. We're going to explore some of our personal beliefs, and I'm hoping to have a big discussion about this afterwards. So we're going to do similar like we do in C-card groups. We're going to have a recorder, but also since this is virtual, that recorder, you're also going to be the reporter. But just because somebody is the designated reporter does not mean I don't want to hear from you. I absolutely do. So we're going to start out with the first 2 questions right now. What are some of your personal beliefs about why people become addicted? And do you accept certain types of addictions more than others? Are there some that give you, like for example, I had a bias against people who used meth for their drug choice, and I had a lot of learning to do in that area. So we're gonna start with those first 2 questions in our group. We're gonna come back and talk about it. I'm going to leave this up for now, but when we come back from our breakout groups, actually, no, scratch that. Zoom doesn't let me do that. So I'll have to stop sharing my screen. So if you want to take a minute to write these questions down so that you have them in your groups, because I don't know about anybody else, but when I get into small groups, I'm like, wait a minute, who am I? Where am I? What are we doing? What are we talking about? So what are your personal beliefs about why people become addicted? And do you accept certain types of addictions more than others? What and why? Okay. We got those? You can just scream at me to put it back, or I can repeat it in just a minute for you. We're going to stop share. See? Awkward. I'll get it down one of these days. All right, so I'm going to put you guys in some groups. Riz refers to charisma. Well, then my kids are wrong. I've got that in spades. Okay, so. All right, we're going to put you in our breakout groups and then we're going to come back for some discussion. See you in a bit. All right, welcome back, everybody. For those of you who are just joining us, we're coming back from a breakout room where we had 2 questions that our groups are working on. What are your personal beliefs about why people become addicted? And do certain types of addictions, or are certain types of addictions more acceptable than others? All right, so who are my reporters? Oh, good, hands are up already. I love that. I'm going to start with John. Go ahead.
Hi, I'm not where the hell am I? I'm not the reporter,
Oh,
Patty.
okay.
I just want to make a comment that I think with a 2 question um exercise, a little more time would be would be required. That's all. Just want to have a comment. Like if we go into another breakout with 2 things to discuss and 4 or 5 people, we're going to probably need a little more time.
Thank you for that
Yep.
feedback. We do only have an hour and a half today. So we are moving through a lot very quickly, and we'll just have to do the best we can. All right, Pete.
Thanks, Patty. Yeah, I mean, we did run out of time. We answered the first question, but like within the last 10 seconds, we all agreed on the second question. That so to answer the second question first, you accept certain types of addictions more than others. Like, no, it kind of, I was sharing in our group that there's this word in psychology, transference. I call it jumps, right? Addiction jumps. Once you quit one thing, something else comes up, right? And then the healing kind of continues. But to answer the first question, what are your personal beliefs about why people become addicted? I'll just read the list that, for us, it started with feeling good, and it's about escaping pain. It's about feeling normal, to numb so we don't feel, mental health, trying to escape. Uh, many of us, if not all of us, we're hiding our pain. We didn't want to feel that pain anymore. And addiction was in the family, and we were escaping reality, numbing everything. So that's what we came up with.
Awesome. Thank you. Yeah. Alex.
Yeah, we had childhood trauma, any kind of trauma really that could at any age, not dismissing age. Um, Escaping suffering, and then Ed said it much more eloquently and beautiful than I did, but basically that that we all share these common, and feel free to pop in, Ed, if you want to, um, share common traits, that our brains are also unique, and that every addiction is enormously unique, though we have common traits, but that we're kind of all equally susceptible. Socioeconomic reasons, identity, covering pain.
Okay. Yeah. All right, Ron.
Morning. What we had for personal beliefs, and we had a variety of different things, but a lot of similar things to the other two. Social environment and the activities that go in, people are trying to fit into what's going on, or called peer pressure potentially. And what do people feel about themselves? What's their emotional state? Quality of their family life, going back to it could be childhood or a current situation as an adult. As far as the types of addictions more than others, like was said earlier, maybe one question by John instead of two, but I get the whole thing. But we talked about identifying with our own addictions more than others because we have the experience with those types of addictions rather than others. And it could also be that there's certain situations, say somebody that's having a sexual addiction that could be uncomfortable, um, that could play into the routine there.
Yeah, absolutely. I'm glad you brought up non-substance related addictions, right? Because we, even as providers, we have to keep our own selves safe too, and knowing when we need to get somebody another resource that might not be us. That's a really important thing to be aware of. Yeah, awesome. Thanks. All right. I want to hear from the other groups. Or was that all of you guys? Was that all four? My goodness, we're flying through this today. All right. So for our second awkward screen share of the day, third actually, um, we're going to move to our next questions that are on here. I swear, I'm supposed to be a millennial. I'm supposed to know all this stuff. I'm supposed to be good at it. It's just not my thing. All right. So do we believe that some people are beyond help? And that kind of ties into the second question, which is, do you believe that certain drug treatment approaches are better than others? And for the last question, we're going to do this as a whole group together to get us moving a little bit. So when we do our groups this time, we will do 10 minutes. And I will make sure that you have that 60 minute or 60 second, sorry, warning before we are brought back. So again, do you believe that some people are beyond help? And do you believe that certain drug treatment approaches are better than others? Okay, did we get those? Good to go, heads nodding, okay. All right, I am gonna open the breakout rooms again. I heard your feedback, so we will put fewer people in a breakout room. And we'll see how that goes. All right, and when we come back, we'll talk about it. 10 minutes, so at 9:37, actually, I think you guys are EST, so it'll be 10:37. Depending on where you are here in the Midwest, it will be 9:37. And then we will talk about it. All right, see you in a bit. All right, welcome back, everybody. For those of us who have just joined, we're coming back from a breakout group, and our questions were, do you believe that some people are beyond help? Or do you believe that certain drug treatment approaches are better than others? And I see hands up right away. This is awesome. Melody.
Good morning, everybody. Our group said the answer to the question beyond help, no one is beyond help. And is there a drug treatment better than others? And we all said no. We talked about it's the willingness. It's the willingness that creates the change. And so you have to want to create the change. It's about meeting the person where they're at, getting a sense of what they have done, what they have tried or done, what worked, what didn't work, and creating an individualized and personalized approach that would work best for that individual. And I had mentioned that years ago, there was only the abstinence base, and now the industry is moving into, harm reduction and smart recovery, and that there are other ways in which to build recovery capital.
Yeah, absolutely. There's so many different things now. So in my house, my kids, they really take pride in being very helpful. Sometimes they're overly helpful. And so a common motto in our house is, if it wasn't asked for, it isn't helpful, right? Like, we've got to think about, like, are we actually helping a person? What is their definition of help, right? Because you're only helpful if they have gotten the help they're looking for, right? All right, cool. Andrea.
Okay, yeah, again, nobody is beyond help. However, certain environmental factors can play into that access to treatment, and then also just like environmental factors that can play into the roadblocks or hurdles that one has to deal with. And then I guess we were also saying whether it was preferable over the other, definitely leaning towards abstinence-based programs, but that there's a place for harm reduction when needed. And anybody in our group can speak out too if I missed something.
Sounds like you're doing great.
Okay, thanks.
Yep. I know that we tend to lean towards abstinence-based, but again, if that isn't what the person wants or is ready to do or willing to do, or even able in some cases to do, then we've got to like reassess how we're meeting them and how we're talking about the individual, right? Awesome.
Mhm.
Thank you, Andrea. All right, John. Where'd you go, John?
He's on mute.
I was so busy lowering my hand, I forgot to unmute. So, yeah, we collectively agreed that nobody's beyond help. But again, like Andrea mentioned, there are resource issues, there are timing issues, physical and mental and emotional deterioration of people. It could be too late that type of thing was brought up from kind of the anecdotal experience of people in our group. And on the second question about treatment, again, Vic and Robert had some significant experience that some methodology works better than others, but that the toolbox is a big one. That the most important thing is to find the treatment that works best, is the best fit for the client. But to say that, you know, all treatments are kind of welcome and equal, we thought would mean that the recovery work hasn't yet is like finished evolving, in which obviously it hasn't. So you know, we're open to think that that improvements will be made down the line.
Awesome, thank you. Rennie.
Hey everybody, good morning. Yeah, I was in the room with Andrea, and I just wanted to add to some stuff. You know, the blockage for somebody gaining treatment might be, you know, something like, you know, I've worked with inpatient substance use and mental health, and a lot of it can stem from somebody having a mental health issue that stops them from getting the treatment that they need, that blockage that they need. Not that they don't want it, but they just can't get it mentally. Whether they're off their medication or they're just not taking their medication, or they're not prescribed correctly, so they can't think clearly. That's one hurdle that really is hindrance. And then the other thing about the different approaches to treatment, you know, I took that question as, you know, I do a lot of work with people who are on MAT, who are on Medicaid assisted treatment. And, you know, the difference between something like methadone and Suboxone is a big difference, right? What's the addictive liability for those medications? Is one really hard to get off and the other one a little bit easier to get off? And I'm fully an advocate for harm reduction. You know, harm reduction sites is like, you know, a safe injection site or something like that. If that's what the person wants, you know, who am I to tell them how to get better? I'm here to show them the way I did it. And if they want that, great. If not, let's find a solution that works for you. But I would probably suggest something, if you are on medications, to try something a little less addictive is what I was thinking. So thanks.
Thank you, Rennie. That's great. All right, Ron.
Thank you. We said a lot of the same things. Our group said no one is beyond help, and but the individual has to want that help, because if they don't want it, most likely they are not going to be successful, at least in our experience that we talked about. As far as certain drug treatments, we didn't think that there were any that were better than others, but the big piece was what's acceptable to the patient or the individual themselves, because it's an individualized journey, and having some faith in which will bring some hope to that person is going to be part of that healing process that they go through. So because they may not want to take drugs, you know, they want to shy away. I know a lot of folks that don't want to have any painkillers or anything else because they're afraid they're going to slip back into, you know, that world that they don't want to be in. But that's what we had. If anybody in the group wants to speak up that I missed something, please do so. Okay, thank you.
Awesome. I'm glad that you brought up wanting it, because that is a part of the conversation that we talk about a lot in the recovery area. How many people have you served that really, really wanted it and just couldn't be abstinent? I can think about at least 10 since 2001 in my experience of recovery. And one of the things that we associate with wanting it is choice, right? But in order for something to be a disorder, in order for it to reach disordered or in a DSM definition of addiction, right? It's beyond their choice. It's beyond that. And one of the ways when we talk about it as though this person wants this, then we start to kind of blame them for the things that come with still continuing to use substances. So just like, you know, when we know certain terms cause stigma, this is one that is a little bit deeper when we talk about it. And and another way that we hear it is that the individual isn't ready, the person isn't ready. My job to create a good recovery space, a recovery ready space, is to make it seem feasible, small enough steps, and something that is appealing. So if that individual isn't ready, I haven't done my job in my space, right? As another peer in recovery. So when we talk about this, it's not talking about, do they want abstinence? Do they want medication treatment? It's not about that. Is what is their recovery that they do want, that we are looking for? Where is the way in, right? When we talk about this in a way that brings full choice into this, that is like one of the building blocks for the stigmatization and then eventually the criminalization. And we're going to get more into that in a little bit. I want to get to Pete. I want to make sure. And I also just don't want to run out of time on you today. So Pete, what did your group have to say?
Thanks again, Patty. Yeah, everyone pretty much touched on it. I'll just add a couple, like from a recovery coach perspective, because some of us are that, that everyone is capable. They have to find the correct pathway, which kind of ties into that second question as well. And it's I like this that our group shared, is the uniqueness of knowing themselves. And even if they don't know themselves, they can start learning about themselves, which is something that you kind of touched on, right? It has to be feasible in small enough steps, and then which is the way in. So that was pretty much the addition. And then, I don't know, an acknowledgement that obviously some people, they die in their addiction. So, but if you're living and breathing, our general consensus is yes, you can get help. Thank you.
Absolutely. Thanks, Pete. David, and then AJ, and then time is telling us that we have to move on, even though this is a great discussion.
Okay, on the issue of are some people beyond help? I think we agreed for sure that no one is beyond help. However, I think it's really important to look at some variables which make some cases way more challenging than other cases, and that could include whether the addiction is also accompanied by some major mental health issues, whether it's linked to another addiction, like someone who's a drug addict plus they have an eating disorder, extremely difficult. And I think the length of the time person has been an addict or have this addiction is also an important variable that may influence how challenging the case is. So it's important for, so in summary, it's important to think about some of the variables that make the case appear at least more challenging or less challenging.
Challenging how?
Well, for example, if the addiction is coupled with something like an eating disorder with a drug addiction, those are two on their own challenging addictions. And if they're coupled, then likely the time it's going to take for recovery is and the way the recovery path is going to be developed, it's going to take a little more time and maybe more resources to work with that person so that they can find their recovery path and build their recovery capital.
When you have a challenge, there's usually a specific goal in mind. So what would the specific goal in mind be for somebody who has is using substances in a disordered way and is eating in a disordered way?
So could you repeat that question?
So when you have a challenge, there's a specific goal. You're looking for a specific outcome, right? If something is difficult, it means that you are not getting the outcome or meeting the goal that you're looking for. So then what is the goal of somebody who is using substances and somebody who is eating in a disordered way?
Oh, I think the goal is, we could agree that the goal is the same. However, the resources we may need to use in the case that we're talking about, eating disorder and drug addiction, are different.
What is the goal? What is the goal?
Not, the goal is they find a recovery path and develop the recovery capital, and they find a way to live a life without an eating disorder and without a drug addiction.
But if they came to you and they're looking for services, they're already in recovery. They're already on their pathway. It's just what is there. See, this is what I mean around the language. Like when we think about the way we talk about things is the way we think about things. When you're talking in German and they have the gendered the a, right? So you wouldn't say, you would say like die Frau for a woman and der Herr for a man. But also this applies to inanimate objects, right? And it's the same in Spanish. And however, in German, you would be referring to a bridge using the feminine D, whereas in Spanish, you're using the masculine L. So when you talk about the bridge in German, you would tend to use words like it's beautiful, it's connecting, it's building relationships. But when you're in speaking in Spanish, you would talk about it as like it is strong and it's sturdy and things that you would associate with masculine, right? So how we change the way that we talk about something changes the way that we see it. And when we're using words like challenging and drug addict and eating disorder, as opposed to talking about that person, we tend to put ourselves in an expert role and have a predetermined outcome. And when we're not getting that outcome, that's when it becomes challenging. Does that make sense?
It does, and again, we can't start with the assumption that this because the person is in treatment, that they are seeking it on their, that they're actually seeking it rather than showing up because someone sent them there.
But again, if somebody set them there, this is not necessarily within their control. And at least in the peer realm, that's not in our scope as recovery coach professionals of doing forced support, right? But one of the things that we do quite often with our people here that we serve is just holding that space and saying, it isn't fair. You shouldn't have to go through this. I'm here for you. What do you need? And especially for using the example of an eating disorder, right? At the root of that tends to be about control. The minute that a person feels that they have some control, they have some empowerment, they have some stake in it, then they tend to want to, move through, but it's got to be their plan. I didn't mean to pick on you or anything, David. You just used some really great words in a language workshop. And so it gave me an AJ, and then we're gonna have to skip that last question and keep moving.
Yeah, I don't feel picked upon.
Okay, awesome.
Okay, one of the things that came up in both of the breakouts so far was, how do we know where someone is? Is there anything we can use? And there's actually a motivational interview tool that you can use called the readiness ruler. And how it works is you'll ask, it's got 3 different sides, kind of measures 3 different things. You can ask them a question and ask them where they are on the ruler from 1 to 10. They say 5. Then it's, why a 5 and not a 4? As they answer that question, now what they see as something that's holding them back. And then you ask, well, why a 5 and not a 6? And, and vice versa, so you find out what they feel is holding them back. And you find out what they feel are their strengths in getting past that. So another thing I noticed is language. Words like case, people aren't cases. They don't need to be managed. Patients, they're not our patients. Client, they're not our clients. They're our equals. Client denotes power, a power structure. So again, our language is, sometimes our language can put them off if we're using clinical language. So we have to watch that. So that's all I wanted to say.
Yes. Thank you this was all really great and productive feedback. So much so it's moving us along in the time. So I'm gonna do my next screen share for the day. And I think a lot of you probably answered some of this. Do we think recovery must look a certain way? And we touched on it a little bit, right? Like when we're thinking about how recovery looks, and if we're not getting that look, that's when we start to think that there's some sort of failure, or it's challenging and it's difficult, right? But if we're truly meeting somebody where they're at, wherever they are, even if it is the pre-contemplative phase and they have to be pre-contemplative in a facility somewhere against their will, that's still their stage of recovery, right? So stigma is reducing the person down to nothing more than their difficulties. It is one of the most damaging and dehumanizing forms of language. It denies the existence of any facet of the person, any relevant roles or characteristics other than their diagnosis. And so this is one of the big reasons why I challenge, usually when I'm working with a recovery for a while, right? Because if their thing is what they need to do right now is just like they need to call themselves an addict. Like, I am an addict. I am a junkie. I need to, they need to do that for right now. This is something that I will let go for quite a while. But once they've had a little bit of success and they feel a little more empowered, one of the things that I will challenge the most is why they use that term. Like, what do you associate with this, right? When we think about the word addict, the first thing I think of actually is jail oranges. That's where my brain goes to immediately. And then I think of, having been starting my pathway to recovery in the 12-step room, I immediately think of people who would be like, well, what do you want from me? I'm an addict. I can't help it. I'm just an addict, right? And so like that, it was dismissive for, accountability. It was used in like this helplessness sort of way. So then when we start thinking about somebody or every time we're saying that word, I'm an addict, I'm an addict, I'm an addict, there's, that association of criminal, helpless, can't get any better, right? Because the way that we talk about it, our language shapes so much of our worldview, and only about 10% of it is fully executively conscious that we realize what we are telling ourselves with these things. And when we talk about wanting to make big change within a person, or later when we talk about power structures, and we get into that tomorrow, like the very least someone can do to make any kind of change or step towards progress is simply just changing the words, right? Like there's not, like that's a pretty simple step. It's the last, like the only thing less than that is nothing, right? The only thing less than changing the way that you talk about something is nothing. And so if there isn't a willingness to change that, yes, and the comments here, negative self-talk, exactly, then we need to readjust as to whether or not, we're looking towards progress at all, coming from a peer provider stance, right?
Yes.
And this takes from, it robs from life opportunities. I know even in my own mind, especially during those times, I mean, calling myself an addict was not the only barrier that I had, but I never, ever, ever would have believed in a million years, even though I was in recovery, even though, I had been for many years, I would have never seen myself as being somebody who could be a content expert on something as language. I didn't see myself as somebody who could finish any kind of education. I didn't see myself as somebody who could run a business and who could speak so articulately and connect with people for a job. I did not see myself as this, right? And how we see ourselves matters. It's one of the reasons that representation matters, because if you can't see it, if you can't imagine it, then you can't move to the next step of really considering it and putting together a plan of action. And so when we're using that language towards individuals or towards ourselves, there is messages every single time that we use that language, that there is a certain slot that you can stay in, and there's only so much you can do, because you have this broken piece of you forever, and that is the only piece of you that matters, right? So it'll interact with the illness and exposes people to distorted experiences with the criminal system, the mental health system, the medical treatment system. I don't think there's anybody in here who has not experienced that or seen that from somebody else. So a story and experience of mine, and stigma leads to healthcare systems that withhold appropriate services. So I was 27. I had 2 small kids, and my knee started swelling up really bad. I kind of ignored it because I'm stubborn like that, and I had stuff to do. And it just wasn't going down. And when, I wrapped it, I iced it. Of course, I didn't stay off of it. But when I woke up the next morning and everything from my knee all the way down to my foot was completely bloated, I was like, I maybe should see a doctor. And so I went into the emergency room, and having been struggling with some chronic illnesses, I really just had expected them to be like, whatever, there's nothing wrong with you, go home. But I had a DVT that had broken off into pulmonary embolisms. Imagine that. That's why I was having a hard time catching my breath. And so they admitted me to the hospital. I did have to be on a breathing tube for a little while. It was quite terrifying. And again, I was 27. I was a young mom. I didn't know what was going on. I knew that as soon as they had started the treatment for the blood thinning, I had a lot of pain. I also knew that I had a legitimate allergy to certain pain medications where I would break out in hives. I also knew that I had other pain medications that if I took them, it made it very, very difficult for me to stop taking them. So I had this all listed in my medical history of the pain medications I can take, the ones that I can't take, and here they are. They withheld the pain medication from me and really, really kept pushing this one medication to send me home with that I knew I was allergic to. And finally, they just kept pushing it, kept pushing it, kept pushing it. And I said, okay, I will take it here. If I don't break out in hives and everything is fine, then I will go home with it. Well, I took it. And then, of course, I broke out in hives. And because my system was already so agitated and there were new drugs in it, my throat started to close and swell. And so after this, I called my doctor, who I had always been very candid with about, where I was at in my recovery and what was going on at the time, because at the time I was a kid in the foster care system going through a lot. And then I hit 16, realized I was going to be on my own, and was like, hey, maybe I'm going to make some better choices, right? And had been completely abstinent from all substances whatsoever from that point on. And so this was, 11 years in for me. So I called my doctor. I told my doctor what was going on, that they're trying to send me home on this medication that I'm allergic to. And then the floor doctor from the hospital came in and confronted me. How dare you call your doctor? Yeah, I see it. It's in your chart. You're just trying to manipulate me. You're trying to get all of this medication because you have a specific one. And I, again, terrified, not knowing if I'm going home. I had the courage to say that was more than 10 years ago when I was a lost kid. But this was a very real consequence for me. And this is things that I have seen happen with other recoveries, where because of stigma and the belief that because I had had a substance use disorder at one time, that I was just, having blood clots to manipulate the doctor into giving me a specific kind of drug. So that it didn't, the mindset was not that, you know, I was somebody who was in need of medical care for a DVT and pulmonary embolisms. I was an addict who also had some pulmonary embolisms, and maybe that's a thing. And she's probably hamming up the pain part to get more drugs, right? So when it comes to this stigma, it has real world consequences that can be and are, as I'm sure you have all experienced, life and death. And so that's why when we're talking about this, that is the very bottom. That's the very bottom of being able to make changes in our systems. Because if we don't change our minds first, how can we invite somebody else to do the same thing? I'm going to check the chat right here. Yes, even Jimmy Kay, the founder of Abstinence Based NA, knew the power of language was stigmatizing. Yeah. Yes. Thank you. Ooh, we're getting into the Latin of it and everything. If you've got a second to read that, but the main point of this today is that this isn't something that's small, right? It's not a convenience or a politeness that we are offering to somebody. This is not that. It's about dignity, it's about respect, and it's about treating the whole person and not reducing them down to what was probably one of the most difficult periods in their life. So, following that story, drug addiction is often treated as a subcategory of mental illness, and insurance plans group them together. This is another instance where, you know, the language and the way that we think of it has real world access consequences. And given starkly different public views about drug addiction and mental illness, advocates may need to adopt differing approaches to stigma. So again, mental health is still got a long way to go, right? For being destigmatized itself. But when we hold that up against somebody who has a drug addiction, there is far more likelihood to offer care and support and services to someone who has a mental health diagnosis. Again, there's still a long way to go of people with mental health needs being included as equals in their plan. I want to be very, very clear that there's still a long way to go, but we're not putting them in jail. We're not telling them it's their own fault. They have to want it. They have to be ready to stop hearing voices. They have to be ready to stop having manic episodes. We don't talk about mental health the same way that we talk about addiction. And while both are equally treatable when given, you know, proper care, many times our systems don't. Even if somebody feels that their mental health is the reason that they need, that their mental health or their mental unhealth is the reason why, you know, they're having a disordered use of substances, as soon as they go to a mental health provider and bring up that they have been using substances to cope with this, they get kicked back to AODA, which is again much more choice-based, much more punitive, much more you have to want it, you have to be ready. This is all on you, the individual, and not your environment, and not something physiological. It's all back to it's you, the individual. So words are important. I love this quote. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And that is a quote from Don Coyes in The White Bison, which if you haven't had a chance to check that out, it's really cool. So real stigma of substance use disorders. In the study, here it's cited at the end, it's by the Recovery Research Institute. Participants were asked how they felt about the two people actively using drugs and alcohol. One person was referred to as a substance abuser, and the other one was referred to as a person having a substance use disorder. No further information was given about either of the hypothetical individuals, and this study discovered that participants feel that the substance abuser was less likely to benefit from treatment, right? Because they're challenging, they're difficult, they don't want to do it. They're more likely to benefit from a punitive standpoint, forcing them to go and do something about that eating disorder, about that substance use disorder, right? Or addiction. They were more likely to be socially threatening. So the criminal mindset with it. They were more likely to be blamed for their substance related difficulties, and less likely that their problem was a result of an innate dysfunction that they had no control over. The very best example I can give you for exactly this one is child welfare. Our organization uses our TA funds to support our direct service efforts for families who are at the intersection of substance use and child welfare. And it is illegal to remove children for reasons of poverty. Okay. So if you have a giant hole in your roof, and this is the thing that is causing unsafety for your children, right? They can, and you just can't pay for it. Like, you just don't make enough. The bills keep piling up. You cannot pay for it. That roof cannot be the reason, because you are impoverished. You cannot have your children removed for this. Okay. If anything, if they were going to open up a case for services, they would be required to help that family take care of that safety issue, right? We would be focusing on what is really causing the unsafety, which is that big hole in the roof. And so for that, you don't need like mental health services. You don't need all of that. You need somebody to help you with your roof. You need some financial support and assistance to be able to get that taken care of. If, however, you have picked up 3 different jobs and you have asked everybody that you can in your life for support, and they were unable to help because they were just as impoverished as you are, and every time you get that money, something else happens, and you just can't, and you've been defeated time and time and time and time again, and trying to fix that roof, and you develop a drinking issue as a result of that, if you develop an alcohol use disorder as a result of that defeatedness as a way to escape the pain of this, well, now nay, if you had not been drinking, you would have had the money to fix that roof. And so now the safety issue is that your drinking is in the way of you fixing this problem, and that means that we can take your children from you, and we will. Also, you need to now go to all of these different appointments, whether you need them or not, because everybody has to do them as soon as they are involved, even though you had no control over the situation. And the only thing that it led you to this, the desperation that led you to this, the poverty led to the alcohol use disorder, whereas they are treated as though the alcohol use disorder is what caused their poverty. And then we know that people who have, disordered use or have an addiction of some sort, it comes from a source of pain. So when you inflict more pain on a person, they will use more substances or dive deeper into that alcohol or into that eating disorder or gambling addiction, something like that. And then we use that as evidence to support that they just don't want it, or they're not ready for it, or they care about this thing more than their children or more than their family members. And so then that stigma becomes, all of this is just your fault. It's all on you. And so they're much less likely to get the kind of help and support that they need because of the way that this is talked about. And when we are having this internalized belief, right, when you are somebody who has all of this reflected back to you, right? And every single person who has control over your life is telling you that this is your fault and the only way out of it is for you to make changes. And you don't have anybody else there to verify the reality that they already know. It's a big gaslighting. Familiar with the term gaslighting? It's large scale gaslighting. That person really starts to believe this about themselves. And then when they believe that about themselves, this is more pain. And then every time that they have a symptom of their, disorder, they believe that they are failing, right? Instead of it being a symptom of a disorder that needs exploration and is telling us that there is a need for this individual that isn't being met, it's a personal failure now. And people were also more likely to believe that they were able to control their substance use without help. So again, withholding the support, withholding the treatment. I mean, how many times have you had somebody in treatment and they, had a reoccurrence of use and they kick them out? They kick them out. Substance use disorder is the only one that we do this with. If somebody was hospitalized for diabetes and their blood sugar took another drop, they would not kick them out of the hospital. They would not kick them out of the place that's giving them the treatment that they need. They would explore what would happen. They would also not tell that individual, well, you just need to want it. You need to be more ready to have a working pancreas. They would change the insulin. They would look at what needs to be, what needs to happen. Is there a surgical intervention that needs to happen? They would be exploring. We would look at this as data and information that this person is having a symptom, and then explore together what they need. I'm just checking on the
Absolutely.
the
I
hated
think you're
donut. Get
absolutely
out.
right.
Awesome. Thank you, Justin.
Yeah. Yeah. I mean, especially if you take in the morality issue where it's seen as you must do things a certain way, or if you have a failing, then you are a bad person and you're not worthy of treatment. Like, I literally had this exact thing happen last week where a client of mine is sober 15 years or 15 months, excuse me. And he's on Sublocade, and he had a random test, and for some reason the amount of medication in his blood was incorrect slightly. And so the administrators of the test insisted that he must have used drugs again. He must have returned to heroin use. That was his drug of choice. And I, as someone who's sober 15 years personally, and I work with addicts and alcoholics every day, and I'm very invested in the field. I believe with my whole heart that this kid who's 27, this kid did not use heroin, and that maybe is it possible that there's something wrong with the test? I've personally given urinalysis tests where I got a positive result from a client, and then they were given another test and that was negative, and then a third test is supposed to be administered. So I I mentioned this to the client's counselor. I said, is there a way to do another test to see if possibly the computer was wrong? And she insisted, nope, once an addict, always an addict. He's just lying. He's going to insist that he didn't use again, and we're kicking him out. We're gonna risk homelessness for this kid over what could have been a computer error.
Absolutely. And that is not a unique story, unfortunately. And the one thing, like many times when we're working within systems, we can't make that much of a change. But the one thing that I can do, and I would invite you to do, is just change your language no matter how anybody else is talking about it around you. They're a person with a substance use disorder. They're a person with an alcohol use disorder. They have this. They are not this, right? Because when you think about the differences between shame and guilt, guilt is, I did something that I'm not okay with. I did a bad thing. And so I need to take action to correct that. Whereas shame is, I am a bad thing and I can do nothing about it. Okay. And shame is good that you can feel it because it means you're not a sociopath. But as far as healing, as far as progress, as far as support, shame is absolutely useless. That guilt is information, right? It's a mistake you made. It's not who you are. And yet we talk about people with a substance use disorder as that this is what they are. This is who they are. There's no other part of them. They are an addict. They're an alcoholic. So when we change our language, I would invite you, just don't tell anybody you're doing it. Just do it and watch how it changes if you're a social experimenter like myself. All right. Let me see. We have time here. Okay. I'm sorry, AJ, we only have a couple minutes, but I'm going to try to leave some time at the end for some more discussion.
Okay, thank you.
Okay. So when we talk about empowered language, we've talked about a lot of the harm that can be done by using that. So what we're going to talk about is how to do it a bit differently, right? What to do instead. Because if I just stood here for this whole hour and a half and said, y'all are doing it wrong, don't do it this way, and didn't give you anything else, I wouldn't be I'd be just like every treatment center, right? No, not everyone, but so words that we use now typically are like an addiction, it's a chronic disease, substance abuse, which, by the way, you cannot abuse an inanimate object. You can abuse people, but you cannot abuse an inanimate object. It is a substance. I would also argue that substance misuse is still too stigmatizing because it is a substance that was made to be consumed. They are consuming it. That is its use. I promise you they're not using it to wash their pots and pans, okay? They are using it as it has been made. They may have some disordered use, meaning that it is causing them problems medically, physically, socially, emotionally, but they are not misusing it. Relapse prevention, recovering addict or alcoholic, and many times that word recovering gets just left out on top of it. We talk about self-help or a consumer, medication assisted treatment, patient methadone client. These are some of the terms that can be very stigmatizing. And again, those subtle messages of what we're telling ourselves and what that person is telling themselves and what we're telling ourselves about that person over a long period of time. So when we think about a language change, we want it to be person-centered because people are multi-dimensional. People are messy, people are layered, and nobody is all good or all bad, okay? Words and concepts that elevate and celebrate. We want to talk more about recovery, the recovery community, right? Person seeking recovery, communities of recovery, advocacy, sustainability, recovery support, recovery coaches, recovery-oriented systems of care, living proof, their story, responsibility, gratitude. Long-term recovery. So when I introduce myself now, I say I am a person in long-term recovery. And what that means to me is I have not had a chaotic relationship with substances since March 17th, 2001, right? This is a more accurate description. It doesn't make this something that I am barred into for the rest of my life. It also leaves possibilities that I have had this happen before. It could possibly happen again. But at this point, it's not chaotic. I'm not in a space where I need to be in acute treatment for a substance use disorder, or I need acute services for a substance use disorder. Any other like positive terms? I'm going to look in the chat and see if anybody's got some other positive terms. I'm Gary and I'm a person. I love that. Am I using it as prescribed? If not, then it is misused. But again, when we're talking about misused, we are talking about a choice, something that they did wrong, which leads over into the moral area. It leads over into it puts it back on the individual. I would say because by definition, if somebody has a substance use disorder, it is a requirement that it is not within their control. Okay. So you have to be in control in order to misuse something. So just when we think about it, instead of it being misuse, it's another, it's a symptom. It's a symptom of the disorder, right? Instead of talking about a relapse or misusing a substance, we don't need to play devil's advocate. He's got enough advocates. So when we're talking about this in a way where we're going to explore, it's a needs-based approach. Somebody has a need that isn't being met, that substance is meeting. And if we can find another more positive way for that need to be met, then there isn't a need for that substance anymore. or they had a reoccurrence of use, because returning to active use again puts that on that accountability of the individual, right? And we're trying to think about this differently. So to have some new words about it, they had a reoccurrence. It was a reoccurrence of use. It was a reoccurrence of symptoms, right? Person in sustained recovery also leans towards that the abstinence is what recovery is. And recovery is a lot more than abstinence. There's a lot more measurements to recovery than just abstinence. All right, so recovery affirming healthcare. It's not a standalone treatment option. It's part of a complex, multifaceted treatment plan, as well as all of the other cognitive, behavioral, and recovery-oriented interventions. They need all kinds of things. Housing is recovery support, right? That's recovery capital. And we want all of the healthcare to be comprehensive, and the plan with the individual in something they feel they can do, as well as things that are medically necessary, like when it's deemed appropriate. It's sometimes used to control the symptoms, right, of chronic diseases. We want to think about its medication supported treatment, medication supported recovery. And we're almost at time, and we have landed right at the perfect spot for today. I was a little worried we weren't going to get through everything. So this is just a really great visual. And we're going to talk about these others things a bit more tomorrow. But these are the places where you're going to hear certain things. In the mutual aid meetings, you'll hear addicts, alcoholics, substance abusers sometimes, opioid addicts. You're going to hear relapse, medication assisted recovery is the more positive things that we want to be able to see, right? You're not going to see this as much in the mutual aid meetings, except for some. So in public, we definitely want to stop saying these. So, you know, when you're in the mutual aid, that's where people are at. If that's what's working for them right now and their individual space, or for you, for your individual space, if that is still the phase in recovery that you are in, and that's what you need to believe about yourself in order to continue your pathway, hey man, I'm not going to tell you no. But in public, these are the terms we really need to stop using. And when we are providers, we're going to stop using this. Okay. If you went to go see your urologist and they started using slang terms instead of medical terms, you might get a bit uncomfortable. I'm sure that if I went to go see my OB doctor and she started, you know, referring to my womb as like a oven or something like that, instead of using medical terms, that would be very, very unprofessional, and I would be very, very uncomfortable, right? So when we are in the role of being a peer in a professional setting, we're going to stop using these terms, and we're going to stop doing it in medical settings, and we're going to stop doing it as journalists. And we're going to dive into why that is a bit more tomorrow. But we only have like 1 more minute, but I still really want to be able to give anybody the opportunity to speak up or add to this just before we leave here today. I'm going to stop screen sharing so I can see all of your faces. There's great conversation and lots of really back and forth. I really appreciate that. Oh, awesome. I'm glad to hear that. The stigma-based language chaining. That's great. We're going to talk about that tomorrow on the systems side. All right. Well, I hope I get to see all of you again tomorrow morning for the second half of this training. I really, really loved it so far. You guys are a great group, and I will see you all tomorrow. So, as more people are filtering in here, I just love to touch base with you. What are some of your takeaways from the webinar yesterday? Nothing. Oh my goodness. I have not done my job. Yeah, Gary.
I'll share. This is not the first recovery language webinar I've been in, so I'm always excited to watch and participate in the learning process and to constantly evolve, which is something that we all need to do in recovery, especially when we're addressing stigmatic language and really being progressive. So I'm getting a lot out of it. I always do every time I'm in one of these things, and I think you're actually doing a really good job. So thank you so much.
Well, thank you. I promise I wasn't fishing for compliments. I really just want to know what everybody thinks. Yeah, Melody. Oh, you're on mute, my dear.
Good morning. Good morning. It's interesting. In participating linguistically, I always find myself curious as to someone who said, I suffer from substance abuse disorder. I'm a recovering this. I'm sober curious. So I think the language creates a bridging of conversation.
Yeah, absolutely. I would agree. Great.
So
Yeah, Rennie. Oh, go
you,
ahead. Sorry.
Patty.
Absolutely. I'm glad to be here. Rennie, yeah.
Hey, good morning, everybody. These webinar, you are doing a great job, by the way. It's so what it does for me is it reminds me of using the language, because in my day-to-day life, I go to the rooms of 12-step programs and I call myself what is appropriate in those rooms. When I come out of those rooms, then I have to live this life of a person in long-term recovery, and it changes the language there in my mind. And working with clients and working with peers, because I work for an IOP, so they're clients here. But when I go become a recovery coach, now they're peers. So it's like I get caught up in where I am in any given moment. So I tend to forget, who I am. So not who I am, but how to speak the language of truth, really, because that's what this is. It's a language of truth. It's a language of love. It's a language of transparency, and it's really all encompassing. So it's really important for me to be on these so I can remember how to talk to people, and not talk down to them. That's not what this is about. Thank you.
Right. Yeah, I like that you said that, not talk down to them. That's important. And then, just like I said yesterday, like the way that we talk about things shapes the way that we think about things. So even that self-reflection of like, do I really want to be sending that message to myself about myself? Yeah, great. All right. Well, today we're going to be focusing less on the individual portions of our recovery empowered language and more about in the workplace and in the media. So, first awkward screen share of the day. Oh, and it's being extra awkward for us this morning. Okay. Nope, that was incorrect. All right. I went and made it real extra awkward, so bear with me. It's my superpower. I'm pretty good at that. Okay. Again, so bringing us back to the wise words of Don Coyes, words are important. If you want to care for something, you call it a flower. If you want to kill it, you call it a weed. And I think nowhere is this more important than in the media and at large. So just either in the chat or you can just use your reaction. How many of you have done yourself a disservice to your mental health by reading the Facebook comments after a news article on an overdose? I know I definitely have. Some of the things that we see in there, it really gives you an insight into what the community at large believes about people who use substances. And that can be very hurtful. I don't know about you, but I have to remind myself that not reading the comments is self-care pretty often. So again, coming back to this empowered language, like even some of what we were just talking about is, you know, I'm in long-term recovery. I've not used any substances for X number of years. Even I'll tend to leave out the idea of drugs or alcohol because I don't want to give, you know, that piece of my identity to an inanimate object because I'm a whole person. So I'll just say, you know, I haven't had a chaotic relationship with substances. Long-term recovery has given me new hope or stability. I've been able to create a better life for myself, for my family, for my community. And I'm speaking out so others have the opportunity to achieve long-term recovery. Like these are just some of the examples. Because if any of you have, you know, maybe your workplace had an article written about it, right? Or you've been a speaker somewhere, right? And that tends to lead the idea that this, you know, one person who tends to, you know, not be from any marginalized communities is this beacon of what recovery is supposed to look like to people who don't have any background or context. They don't, you know, necessarily know anybody in recovery, or they haven't experienced it. I know with the opioid epidemic that is becoming less and less common. At this point, pretty much everybody knows somebody, has a family member, friend of a friend. Teenager in a high school, they know somebody at this point. But when we put recovery as a whole on a single individual, that's where it gets very difficult to showcase or make a case for what recovery is. Because how many people do we know that maybe have a decade of abstinence but are still maybe engaging in predatory activities, or maybe still getting in fights, or still, you know, doing things that are maybe not completely up and on the standards, or on like social standards, right? Or people who have been in recovery for a long period of time and still live in a lot of poverty, right? So having any one individual who is a fallible human being, and we all get to be that, right? Be a symbol in the media and for the world at large. One, it strips that person of their autonomy, and two, it really can harm the recovery community because everybody is learning in their process, and many times we learn through mistakes, sometimes really hard, messy mistakes. And if those end up being very public, it sets the whole movement back. So when we're talking about this, we want to talk about it as being made up of many, many, many people, friends, families, allies. One of the biggest setbacks for stigma when it comes to the recovery community as a whole is that we've had to recover anonymously in church basements, right? And it's been, there's a reason for that, right? Because the stigma is real. You can lose jobs, you can lose friends, and as we talked about, you know, healthcare, there's real risk to the people in the recovering out loud. And there's been a much bigger push and bigger movement for that collectively, not just in the US but worldwide. So when we're representing it, like the type of language that we want to use, here are some examples. The recovery community is made up of people in or seeking recovery from addiction, their family members, friends, allies. Remember, we don't want to talk about addicts seeking recovery because nobody wants to help an addict, but they do want to help people. Okay. So we talk about what we support. There's many, many pathways to recovery, right? That's one thing. When I talk to people, when I meet with my other peers, like I tell them that the biggest difference between a coach and a sponsor is that a sponsor is one pathway to recovery, whereas a coach is a pathway to many. Will help you get to many, however you want to do it, right? There's limited scope of what a 12-step sponsor can offer, whereas a coach has these many doors to open for you: professional treatment, faith-based, religious, mutual support, mutual assistance, navigating the criminal legal system, drug courts, getting medicated assisted treatment. What are some others? What are some other language that we would use? You can pop it in the chat or come off mute, that's fine. I'm looking at the here. I tend to stay away from the social media use. Yeah. Yeah. Talking about harm reduction. Yes. Yes. Those are some other good ones. We want to talk about like, yep, smart recovery and sustained recovery, right? Not just long-term recovery. And I would even invite everybody here to get really, really comfortable with the word recovered from substance use, because we're no longer in acute care. We're in remission from. We have recovered from. And sometimes the recovery community itself can be the biggest barrier to having this idea that you can be something other than broken, right? I have recovered from. Sometimes I do that on purpose just to make the room uncomfortable, but it's when we're talking about a medical condition as it is, especially in the media, some of the most common understanding of it is that you will never, ever, this will be something forever. This will always be a problem for you. And many times the community at large and other entities and institutions get built upon that. And it's because of the way that we talk about it, even though there are several peer-reviewed studies that show, given a few factors, that somebody's brain can heal within a period of 5 years to operate the same as somebody who's never had a substance use disorder at all, right? So the idea of once an addict, always an addict has been completely disproven. And so we really need to challenge that when we are in the media. Yeah, Andrea.
I was just gonna say that's kind of something that I have to bring this back to my work, and I know my boss is somebody who definitely is. I'm an alcoholic. I'm always an alcoholic, and is very passionate about people identifying that way to understand that they can never go back. When you're talking with somebody who wants to stay with that language, how do you navigate that?
Well, that could be a little bit more difficult when it's within a workplace. I'm assuming this is in a workplace.
So either or, workplace, or when you're working with a client that is preferring that language as well.
When we're working with a person who is using that language, we meet them where they're at. Like we, as the person, across the desk, are still going to continue to use the language that we know is empowered and then we know is in line with factual information. But when it comes to a boss, that does get a little bit sticky. Challenging those things can be hard, especially if they have taken this thing as a part of their core identity. So it's going to be different for every person. But in a workplace, I would start with presenting data and the studies. And like this has been shown not to be true. I hear that for you can never ever go back. And for many people, they can never ever go back. But that's not necessarily true. And when we have somebody who is really struggling with the idea of having to do something forever, one day at a time, then, we can let them, sometimes it's a relief for them to know that it may not be forever. Like everybody, and then many times I have seen where people cannot even think about the one day at a time, but they can't think about doing it forever either. But knowing that there's a certain period of time at which they could explore it again brings relief. And many times they do explore it again and decide that it doesn't add any value to their life. So they just continue to stay abstinent anyway. And some don't, and some are completely fine. And I think one of the things that we need to, when we're disseminating information, we're disseminating in workplaces, and we're disseminating in the media, is make sure that the people who have been able to return to social use still get counted as part of the recovery community, because abstinence is not the only measurement of recovery, and much of the language that we use now all gears towards that recovery is just abstinence. Oh my gosh, lots of hands up. So I think I saw first Vic.
Hi, you hear me?
I can, yes.
How you doing? So I don't know if I misunderstood you or which is whatever, but so you're saying that I'm recover. So you're saying that you can tell a person in recovery that he or she would never ever use drugs again? I got confused on that part.
They may or may not, but that doesn't mean that they have gone back into full-blown addiction, because a substance use is a spectrum and disorder is a spectrum. So I can't necessarily tell anybody that they would never ever use drugs again, but there is a possibility. There are many people who have had extended periods of abstinence and have gone back to kind of explore whether this is something that they would need or they would find any value in it. And many have found that they're just like, it just doesn't do it for me anymore. So I have no desire to continue doing that. And then some people have been able to return to some social use that hasn't caused any kind of disorder in their life. Many
And
people choose not to, and many people at any given point in their recovery, still live with the fear and the trauma and the traumatic experience that led them. Many people call it their rock bottom, and they hang on to that for a long period of time and in acute care in their recovery. But in an extended period of time, many don't. And
I
unfortunately,
get
many
it.
of them don't get counted towards part of the recovery community.
Yeah. So for me, I'm at a point that it's not even me no more. It's like you said, like I don't even think about it, nothing. It's just totally different person, and I just don't look back like that. But having said that, I can't do a whole day. I can't. Some people can, but I can only go by second, and I still have that. Even though I said what I said earlier, I still have that seed in my mind, looking in the future with everything that I have accomplished so far in my life. As of today, I still wonder, that lingering wondering in my mind. Even though I am over it, it's just what I go through, here and there.
Yeah, and on an individual basis, everybody will have to grapple with that. That's a part of the recovery journey, which is again why we can't in the media project any one particular person, because in all of the different phases in recovery, to put it on simply one person and one person's pathway or what phase of their recovery they're in, strips away from the whole of what recovery is. All right, next I think I saw Daniel and then Ed. Oh, can't hear you, Daniel.
I apologize. I'm driving right now. Um, but what I would like to say is because what I've just received from what you just said is revolutionary, because normally I go to NA meeting and I always say I'm a grateful recovering addict and alcoholic, but using the word recover gives me a more positive sense of myself being that's person first language for me. And also knowing that, not looking at it as a way of saying that I'm recovering or I'm a person in long-term recovery, which also gives me a way of saying, well, I'm not fully recovered, where I haven't had the need to pick up a drink or a drug for almost 18 years now. But also too is I'm a certified peer recovery specialist, and meeting my members where they're at. I'm also will give them the autonomy to decide what how they would prefer to 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 identify themselves.
Yeah, absolutely. Thank you for that, Daniel. There's some questions in the chat. What may not be forever? Are you saying that addicts / alcoholics, or people who had a substance use disorder, can go back to using without falling back into their old ways? Yes, some can, and some choose not to altogether. Okay. Then we had Ed.
Thank you, Patty. I am so enjoying this session. And I love the focus on the empowered language. I'm looking at your slide and it says recovery community is made up of people in or seeking recovery from addiction, their family members, friends, and allies. And then it continues, we support many pathways to recovery. We're talking about empowered and importance of language, but I still think that we are not talking to a certain group, and that is older adults with substance use, who experience substance use. I work with a number of older adults.
Mm-hmm.
And actually, there is a lady by the name of Kristen Weir in American Psychology publication in last year wrote, ageism is one of the last socially accepted prejudices. And if we see it on commercials, we see it everywhere. We see it. Go into a Walgreens card shop. Half the cards are humorous about older people. Even families working with older adults, we say we meet them where they are, where they're not in the treatment centers. They're at home, unable to drive, limited mobility. We want them to use their cell phones to virtual meetings or connections. They don't know how yet to figure it all out. Some do, some don't. All I'm saying is, have you, and how do we take this empowered language so that we can also apply it to adults, older adults that seem often to be ignored?
Yeah, absolutely. So again, back to having any one individual being the image or the mind of recovery, expanding where the recovery community is, especially in workplaces and the media, to include everyone, and include, yeah, absolutely, to include elderly generation as well. Much of the treatment systems, I mean, there has been some progress, but much of like treatment systems and much services are for people who are able-bodied, single, and unattached, right?
Right.
That really doesn't include everybody. It definitely doesn't include women. One of the biggest
right.
barriers to being able to get into treatment is child care or even pet care, right? And being able to have somebody come to you is very difficult to find, which is something that the older generation, from what you're describing, would need. They would need somebody to come to them, right? So
Yes.
when we're talking about, when we have the conversation about recovery, broadening our language and broadening the way that we talk about it, and we start including our friends, our family members, our allies, that's when we can start making a movement, because then others who maybe do not have also our specific lived experience feel like they have a stake in helping further this cause to get better coverage, better conversations, and more people included, in anybody in any spectrum of substance use disorder, be able to get what they need as well. So thanks for bringing that up, Ed.
You're welcome.
AJ, and then we gotta keep moving. I love the discussions. I love the dialogue.
Yeah, according to the SAMHSA definition of recovery, each person defines their own recovery.
Mhm.
So this type of empowered language and the fact that you can say I'm recovered, if you have met the recovery you defined, you are recovered. So I know that's in direct defiance of some of the 12-step programs, but it's it's like if you have gotten pre-diabetes and you changed your diet and everything and you no longer have it, you're recovered from pre-diabetes. If you have a heart condition, you had a heart attack and you went to rehab, blah 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 blah, you're no longer a heart patient, you're recovered. Same difference.
Yeah,
And
absolutely.
Ed, I'm glad you brought up the elder population because I have been advocating that for years.
Absolutely.
In
Thank
Wisconsin,
you.
we have CCS, which is across the spectrum, and that is supposed to be a community-based program. They're not supposed to have to meet with the provider in the office. The provider should be going to their home if that's what they choose.
Yes. Thank you for that. Okay. So again, when we're talking about it, it's more broad. We're 25 million Americans in long-term recovery. And we are living healthy, productive lives, supporting families, building our communities, and contributing to society. Okay. So on the point of news articles. So we want to be supporting recovery and talking about how it improves public health, reduce costs, increases productivity that bolsters businesses, which is true. The recovery community does bolster businesses. And when we have more people who are recovered, that means they're working. That means they are also tax-paying citizens, which means any of the cost that it covers or that it takes to get somebody through treatment, to get somebody through services, to get them, access to the recovery pathway is paid back over time, right? Still checking the chance. What is considered long-term? Again, that is going to be on an individual basis. Typically, that language starts coming around 2 years into their recovery or so. But that is going to be on a case-by-case basis. I know for me, I've been in recovery since March 17th, 2001. It's been a long time. That's all I'm saying. I'm not quite elderly yet, but I'm definitely a dinosaur. Yeah, Michael.
Hi. So it's funny because I had a conversation with somebody about this, and somebody that had it was going into 2 years in recovery, and they were like, "Can I say now that I'm in long-term recovery?" And I was like, "What do you think?" And they were like, "I don't know. I feel like for saying that, and then somebody that has 10 or more years, then that's a disrespect." And I said, "Well, look at it like this. Is this the longest you've been in recovery? Then you in long-term recovery."
Yeah.
Right? That's how I
Absolutely.
look at it.
I also fail to see how it would be offensive for somebody at 2 years to be saying they're in long-term recovery compared to somebody in 10 years. That's lost on me. I don't see why that would be offensive. Absolutely. All right. So more examples are, we're talking about individuals, we're talking about families and communities. We got to proactively work together. So in order to do that, they have to have a stake. A lot of the language that, in my early recovery that I heard is that they're a normie. They're either in or you're out, or they're back out there again. Yeah, so-and-so is back out, right? So they're not on the inside. So that means that they're not part of my community, right? So there's that isolationist, that separation piece of things. And in order to stop the stigma and help other people understand and help us move this movement towards better services, is to empower the other people who maybe don't have any direct lived experience, or they are, have been frustrated family members. In order to get them to understand, we need to include them, and we need to make space for them as well. We want to educate our healthcare providers. We're going to implement, routines, prevention and screening and education for substance use disorders, risk factors, comorbidities, right? The old, is it the mental health that's driving the use, or is it the use that's driving the mental health? And you know what? Both and, either or, sometimes it can be all of it. Either way, we all want to be able to see somebody living the best life that they want to be living, right? And so we're just going to treat individuals with the respect and dignity. Many times when we come into our systems, when we come into anything with, the healthcare system, or even the news media or our workplaces, substance use disorder is immediately treated as if you don't know what you need. If you did know what you need, it's just a manipulation that you're lying about to get, and that I know better than you about what you need because your best thinking is what got you here, right? As opposed to thinking of this as a disorder where their brain was affected by it. And with a little bit of clarity, most individuals are their own best resource. They know what led them there. So when we talk about this, we have to talk about the dignity and the respect and the way that people are treated as their own best resource, right? And the language matters. Fight the disease, not the person. Fighting anything means that there has to be an opponent. Anytime we have to target a challenge or a struggle, that is one way to engage people in this, but it also promotes aggression. It promotes, even on a social, on a micro scale, right? And that still ends up being at the person. Not only that, when we talk about fighting the disease, especially something that is under the category of mental health, we're fighting that person's thinking, which then gets back to fighting that person. So we want to talk about addressing the needs and addressing the treatment, not a disease. And we want to do this with the person. We always want to be power with and not power over. And many of our systems are designed to be power over. And some of them even control every aspect of somebody's life, right down to who they can have a romantic relationship with, where they can have a job, where they can live, who they can live with, who they can talk to, what they can eat even. And when you control every aspect of somebody's life, of course, you're going to get the outcome that you want. And then if we can just blame the disease for anything that happens afterwards, as opposed to leaning in with those things with curiosity, and having a conversation around need. You guys are super active today, and I'm going to try to make sure that I can keep an eye on the chat and get everybody's involvement, but we've got a lot to get through too. Okay. So again, when we're talking to policymakers and the media in particular, we want to emphasize the need for more research, which has been happening. Like I'm almost exhausted with how many times we're going to go and gather all the data. I'm pretty sure we have the data. Let's make some action, right? We want to talk about like recovery-oriented systems of care and recovery ecosystems. So how are our resources working together? How are they affected by one another, even if they're not the same thing? And how is the recovery community affected when those change or one goes away? Or how are we reaching out to local businesses? How are we, looking at after school programs for kids who are impacted by this? Like all of the different pieces of this create that ecosystem that will hopefully then build more recovery capital. And we want to be including people who don't have limited or have limited information about this, because if we can invite them in, they then are going to become our barrier. And one thing that I would say more than anything that we need is recovery empowered media coverage. So next awkward screen share. It is not going to let me do it. How many of you have seen the images that come with, I'm going to have to do this to stop sharing for a second, guys. So how many of you have seen media coverage where the pictures, it might even be an article on recovery, but the pictures don't necessarily match the message? How many of you have seen some of that? So even when it's good, we end up having some miscarriage of justice, I would say, when it comes to our people. So here's an example right here. This is even a good one. Exclusive: U.S. overdose deaths plummet, saving thousands of lives. Does he look like he's living his best life? Does this look like somebody who's happy and productive and somewhere we would all want to be?
No.
Even when we're talking about people who want to help, we're still looking desperate, hopeless. Everything is always about the crisis, right? There's an ad we didn't need. Or, my goodness, okay, that changed on me. So even when we're talking about how stigma kept people out, right? And we're going to recover out loud, everything is black at the top, and you have to really, really look to find the people, right? And even this kind of perpetuates some stereotypes around, you know, oh, they're just party animals. They just, you know, they don't really want to get it together. They don't want to contribute. And somebody who is maybe not necessarily as invested in this is just going to, you know, go to the stigma and of what they already know, right? Here's another example. Even when this one is very hopeful, it's just a stock image. And everything, the way that they talk about it being controversial, again, it's addiction. It's a specific drug. We're not talking about the research. We're not talking about, you know, the impacts of this or the collective impact on it. We see a lot of this. So this is where we have to start holding our journalists accountable. And asking very specifically for very specific pictures. So we want to make sure that when we're talking about this in the media, that we have, we've got images ready to go that are approved. Everybody's okay with this. It's a group of them, possibly, you know, a diverse group of everybody that we would see. That's really representative of what our recovery community is. So this is just talking about the report discussing the public health approach to the opioid crisis, which again, when we're taking a public health approach and we're having a public health conversation, although I don't know about that in our country, did we just see everything that happened with COVID? That didn't go very well either, did it? That was strictly public health and sickness. But when we're talking about, you know, substance use as an issue for public health, as it is, and we take public health approaches, we see a lot more improvement. When we think about the social determinants of health for an individual, we're much less likely to see a rise in disordered use happening within, excuse me, within our country. Yeah, Melody, I see your hands up.
Hi, okay, hi. So I'm like back 3 or 4 slides ago, in what I wanted to say. So, I'm a woman who's been in recovery for 37 years. I'm a woman that was probably one of the only women in the rooms, you know, when women had a really limited seat at the table. So when I hear about long-term recovery and that usage, it's really, well, what does that mean? And how, you know, what is that linguistically? I'm also a woman that has recognized that the retirement age individuals in this country has increased the usage of drugs, alcohol, and substance abuse disorder. And so as the language changes and our relationship to the language changes and our ability to create change within the community and the faces of, and the way you described the difference between what a coach is and what a sponsor is, which was beautifully articulated, it's that I feel that I am a representative of what recovery looks and sounds like. And so I have to be very cognizant of what I say and what I do and how I present. So, I'm used to saying who I am and what I am and moving into a level of comfort. The one thing that you said that was really interesting to me was that if you have recovery and you choose to return to possibly usage, that you still are in recovery. And
Yes.
that's a whole nother spectrum. And I found that really fascinating, that I don't dictate what your recovery is. You dictate what your recovery is. And that's very, very new in the industry. Loving the class, Patty. Thank you.
Awesome. I wanted to just slightly challenge something in there. You had said, Melody, that you are a representative of the recovery community, and so you have to be very cognizant. I cannot tell you the number of people, more so women, but not just women, that the root core of their disordered use is perception anxiety. And for those of you who have not come from a class where perception anxiety is prevalent, this is the idea of that your very existence in your life or death situation depends on what other people are thinking of you. And you have to be constantly calculating every single move that you make in order to present the image to others that is in alignment with yourself, or at least what you want them to see and what you don't want them to see. So that is something that this is another reason why any one person cannot be the entire spokesperson for the entirety of the community. Because for somebody, it might give them for one person, it may give them a great sense of pride to know that I represent, part of the recovery community. And so I am going to make sure that my behavior is in alignment as such. Whereas for someone else, that is the most terrifying thing you ever just told them, is that now they represent this community, right? And so there's such a broad spectrum of people who are within the community. It is important. I saw somebody else in the chat say that at the root of what their disordered use was the fact that they were grappling with the fact that they were trans. And once that was addressed, the need for disordered use just went away. And in my own experience, the route for me was the removal through child welfare system. And I didn't even get the opportunity to recognize that as something that is traumatic, because everything I had been taught was that that is what saved me and that I should be grateful. And I had these opportunities to have such a better life now. And there was a time, when I was in my early 20s, that I would have told you that the system is what saved my life. But in fact, it was the root of what my deepest pains were. And once that was addressed, the self-hatred and the need to soothe that or medicate that, it just went away. I have no desire to hurt myself in that way at all anymore. So when we are addressing this with dignity and purpose, and remembering when we're speaking, and only when we're speaking, not necessarily in our day-to-day lives, because we also get to still make our mistakes and we still get to be human beings. We're not just the recovery community, we're also musicians and employees and mothers and brothers and sisters and pretty much anything else that you can think of, right? We are community members. We are not separate from the greater community at large. Interestingly enough, just because language is so fascinating with me, like the very first step in laying the ground for a genocide is the language and how we talk about it. Okay. And so, and that is the first step in creating a separation and a dehumanization. And even in our recovery community, we have been complicit in allowing us to be dehumanized because we haven't used empowered language. There's a number of other factors, and I don't want to get into like the idea that of any sort of victim blaming, but the one thing that we can do, that we can have control of, is just eliminate certain words from our vocabulary, removing the word abuse ever. It is substance use always. And when somebody else uses those words, just gently remind them it's substance use. Right. All right, AJ.
Yeah, something I always try to remember that I learned very early is the word humility.
Yeah.
And when I am speaking to a group, a public group, I always add, and I'm only human, so don't expect miracles either. And people are only human. We all make mistakes. So, that tends to put the audience a little more at ease too. Anyone, especially people who struggle with substance use. That you're only human. You can only do what you can do, and we all make mistakes. So if I say something wrong, don't be afraid to correct me. If I say something you don't understand, don't be afraid to ask me a question. So putting on your human face rather than your expert face.
Yes, absolutely. Thank you. I like that. Your human face, not your expert face. I think also when we are having conversations about this in our own, because we're, especially the people who have the direct lived experience with substance use disorder and the experience that comes with that is oftentimes through the criminal legal system. There's this almost urgency to prove we're not bad. And so we want to put up that image and we want to be the first one to come and speak out. And many people do. And sometimes that's a very, very helpful thing. But if that person gets tripped up and has a reoccurrence, then, there's a very public consequence for that as well. And that shame spiral can go very much deeper. All right. It's good stuff going on in the chat too. I was sick a couple of weeks ago and I took a double dose of NyQuil, technically misuse. Again, that word. Through certain lenses, my recovery of 16 years would be completely negated. Yes, right. And isn't that interesting? Even if it had been, a break, considered a break in abstinence, not necessarily a break in recovery, but then, all of the experience that you gained in the last 16 years would then no longer count. Right? So when we think about recovery as more than just continued abstinence, it's empowering and it broadens the scope of things. And then when we do see a reoccurrence of use or something, we would say, oh, well, what led up to that? When we think about it as like a symptom, if we think about it as like a fever, when you have a fever, you don't go, well, I suck. Now I'm not a healthy person anymore. I need to just stop having a fever. We don't do that. We go, oh, I'm having a fever. Is this bacterial? Is this just a virus? Do I need to drink fluids? Do I need some ibuprofen maybe? Or homeopathic remedies, depending on who you are, chewing on some bark maybe, I don't know. But, we lean into that with like, what do you need? What do I need? We're exploring it with curiosity. We're not shaming it and shutting it down. And how we talk about this can lead to that. So when we're talking about preventing stigma, the language is like the very least, the very low bottom thing that we can do. So we want to learn more and we want to encourage people to learn more. There's no shortage of accurate information about SUD treatment and recovery. There was a question about data on the things that I talked about with people returning to use. Yes, there are several NIH peer-reviewed studies When I say several, I mean 2 that I'm thinking of. There may be more. And there's Stanford and Harvard studies on SUD that do talk about more long-term recovery. There's also a really, really interesting study that says a full recovery, depending on certain, again, some variables, that a full recovery can take up to 15 years. And the things that are needed within the different phases of periods of time of abstinence are not things that tend to be supported. So when we are talking about data-driven, evidence-based, we want to encourage, we want news articles and we want media and we want workplaces to be encouraged and engaged in learning more about this. And so the speak out, as soon as you learn more about SUD treatment and recovery, the more likely you are to notice when there's misinformation, prejudice, right? There's that prejudice that recovery is abstinence, and we should always be working towards abstinence, even in harm reduction spaces, as opposed to genuinely meeting the person where they're at and what they want for their life and their experience, right? That one's been really, really hard, even within the recovery community. But definitely within our institutions and healthcare systems. And this can, strengthen stigma around it. So we want to talk about the adverse effects of stigma. We want to share our stories of how we were treated differently because we had substance use disorder in our medical history. Yeah, Gary.
Yeah, I just want to share this little bit real quick. I'm in the unique position that I was able to create a brand new agency. And, I run a peer recovery support center in the process of building an entirely new agency where we're going to have hopefully housing, transportation, and a clinical component as well. But in building this, really thinking about a recovery oriented, care place, I've made it abundantly clear to everybody who works here has lived experience with substance use. I've made it abundantly clear to everyone, we have a hard job, we all have these things, and recurrence of use of symptoms happens sometimes. And, it's okay if that happens. Your job is not dependent on your abstinence. And I had an instance of this happening. A person did return to symptomatic chaotic use, and I ended up having to fire them because that stigma was so deeply ingrained in them that they couldn't come and be honest and use the supports that I intentionally built into this system to meet them where they're at, to show them the compassion. It was just so deeply ingrained that they couldn't be yeah, I'm struggling and I need help, in which I would have been what do you need? Absolutely, what do you need? So their performance continued to decline to the point where they couldn't actually perform their duties of their position any longer. But that is not on that person. That is that deeply ingrained stigma within that we all have. Most of us have that. So in building this stuff, it's really hard. It's really hard to change the language, not only within the system itself, but within ourselves. It's really hard to recognize, like you were saying, Patty, that we're not broken, we're not bad, we are able to recover and we can improve our lives, and that the be all end all isn't abstinence sometimes for the individual. So yeah, this is a really, really tricky thing to do. It's a really hard thing to internalize, and it's I think it's a very hard thing to teach, and it's a very noble effort to do so, though. So that's all I wanted to share.
Thanks. Thank you for sharing that, Gary. Actually, it is an excellent example of how the messages and the wording that we get and how that becomes internalized, and then it becomes a part of shame as opposed to guilt. Whereas guilt is useful. It lets you know that, hey, I did something I'm not okay with, right? Not necessarily anybody else's moral compass, but I did something I'm not okay with. Whereas that shame is, I am that thing that I'm not okay with. And many times there's self-punishing systems that are built in with that, right? That then become circular, and people get stuck in that. And stigma helps keep that person, like, it's almost like a guardrail to just keep them inside that hamster wheel of like, I got to punish myself. I'm so terrible. Now I'm in so much pain. I've got to use to deal with the pain. Oh no, I used, and it's back over and over and over and over again, right? And then sometimes the really chaotic disordered use is the means by which they use to punish themselves. And this is what happens when stigma gets internalized. And while the internal piece of that is on the individual to address and forgive themselves, and find new support, like what we can do in the community is give them no excuse to need to punish themselves, right? And that's really the work of preventing stigma and changing what happens in the media and changing what we see said about ourselves and about our community, is so that it can be as simple as, oh, that really wasn't cool. I'm going to talk to somebody about it and do something different, as opposed to getting stuck in that trap forever, right? Or until you die, because many do. So we want to speak out. We want to learn as much. We want to correct it gently when we hear it, because so being somebody who is very particular and concise about my wording, and somebody who tends to use vocabulary that is not common, I've learned people don't like a know-it-all, and they don't like being corrected. So we always want to invite this, or one thing I use a lot is a little like, ooh, are you open to some maybe challenging clarification? Or can I ask you a challenging question? Are you open to that? And then, of course, if they're not, then you know where they are. But this way, you've at least given them the opportunity to give consent, which they're much more likely to consider what you said when they've given consent. And we want to keep hope alive. People who are still experiencing use or chaotic or disordered use can still engage in behaviors that test the patience of others, but they can also reach people who are also still in chaotic use. So we talk a lot about the seed being planted. Yes, AJ, hitting people with baseball bats is also counterproductive. Although sometimes I would at least like to start slapping, but I don't, because I'm an adult now and I'm representative of the people in recovery. So I can withhold those impulses. But we want to remember that even though, somebody may be returning to use and that's not something that they wanted for their recovery, so they would not consider themselves in recovery, but maybe in, active disordered use, they can still reach out to others. And sometimes that might be even more effective to somebody else who would never start thinking about or even contemplating a pathway of some sort of recovery for themselves, right? Everybody is a part of our community. It's going to be frustrating sometimes because you cannot help but get attached to outcomes. You can't help it. You're the most effective when we're not attached to outcomes, but we're human too. And last but certainly not least, we're going to treat people with dignity and respect always. Okay? We're not going to make anybody stand up in front of an entire room and raise their hand and say that they used today, and now this colored key tag it means that you've lost all credibility within the community. We're not going to do things like that to people unless this is something that they directly feel like they need to do in order to move forward. We're not going to require that of them, right? We're not going to require them to go through every single awful thing that they've ever done in order to get some sort of forgiveness or redemption. We're going to just treat them as a person who's in a tough spot, or is maybe even not in a tough spot, but they're just contemplating a change. And this could be your coworkers, your friends, your family, even if you're not aware of it. These are things that we want to bring to the attention of people, particularly who are not a part of the recovery community. They don't realize many times how much, stimulants are used in order to become super productive and to keep up, like even so much in the nonprofit space, right? The expectation of the workload for the pay, and the workload for just, you know, people on a skeleton crew. So many times people don't realize how much stimulants have powered getting all of that work done. And that's something that can end up spiraling out of control real quick. I mean, sleep is one of the number one things that gets people tripped up in recovery and not getting enough of it, right? And people just simply don't, they just don't know. So we don't want to think of them as, you know, normies and addicts. We want to think of them as, this is my community. How can I rally my community? We want to think about, in the media, we want to make sure that we're talking about a whole person, not just how bad it was, what happened, and where you are now, but what are the other parts of you? Like, what are your hobbies? What were your dreams when you were a kid? What did you want to be? I wanted to be a marine biologist. That's what I wanted to be. I probably still do. Fish are pretty cool. But we want to the whole person. Just somebody who is just that someone is addicted, it's only a small piece of information about that person, right? And when you only have the addicted piece of information about people who are having, you know, overdoses, particularly in the media or in a workplace, when all you know about that, people make up a lot of things about somebody who is addicted. And it's usually not that that person is in pain, okay? We're always going to watch our own language. Words can heal and words can hurt. Words can poison. And not just words, but also images, right? Like those examples and the headlines. Some of the headlines might have even been hopeful, but it is still presented with somebody who still is maybe in a derelict position. They're still really struggling with homelessness. And people, unfortunately, even though, you know, homelessness is the simplest thing to fix ever, they're only homeless if they don't have a house. So just give them one. There's so many houses that are simply sitting open. You give them a house, they're not homeless anymore. So we tend to not want to help somebody who seems to be like such an overwhelming need that they don't feel they can fix the problem. So we want this to seem like it is something that is doable, that it is something that is possible, and with your help, we can do it. I would also add, this is just a side note, that depending on the social class that you want to reach, how you word things helps a lot. When we're looking at like above, you know, upper middle class, we really want to use like savior, hero, we can't do it without you type of language. And you on your own, you can heal this thing. Versus when we're talking about, you know, working for lower middle class, middle class, and even into some of the upper middle class, when we're talking about community and rallying and doing it together, that kind of language is much more effective. So also just, you know, if we want to include everybody, we have to really include everybody and think about how the language we use will invite or not invite the person that we're trying to engage, right? Especially in the media, especially in marketing materials, and especially in getting your name out there as an organization and what you can do and how you can get that funded. And we don't want to define people by their disorder. People are more than their health problems. You know, we don't, you know, talk about the diabetics and the cancers, right? We talk about, you know, people who have diabetes, or we talk about getting them their insulin. You know, we don't talk about it the same way. So when you see headlines that are like from addiction to grace or something like that, something real, like sensationalized, like that gets a lot of clicks. It's really nice for the feel goods, but for the long term process, we want to be more intentional about the not defining somebody's worth by whether or not they're having symptoms of their medical disorder. right? And that brings me to the last part of, we're not going to sensationalize the addiction. There are dramatic consequences, and I will own that I very much struggle with this because it elicits disgust in me. And I work really hard on forgiving and being understanding, because if I'm going to meet people where they're at, I have to meet people where they're at, not just people who have had the same experience as me. But there are many people who want to use us as some inspirational high, to elicit good feels in themselves, even sometimes at the very great cost to the person who is sharing their experience. I'm sure many of you have been to a panel where people use their lived experience for, you know, people who have never experienced that, and then they end up asking really intrusive questions that are, you know, they feel like now they have shared something with you, now they know you, so they feel like entitled to this information. And many times, you know, we can feel like the person who is speaking on this panel can feel obligated to give that information because, you know, with all of the internalized stigmatized reasons, there's a million reasons why they would feel obligated. Maybe they don't feel worthy of being there. Maybe they feel like they're paying back something that they owe. But this can end up being something that is a re-traumatization of the person who is, you know, this is all very well intended. It's a, you know, an iatrogenic harm, but that is what sensationalization can do to the individual, right? But we don't want to diminish any of the fact that this is a treatable condition. It's a medical condition. Yes, boundaries do help. One thing that I have found that I'll do is I'll just answer the question I want to answer instead of sharing that information. Or I have just said, I'm like, you know, I don't really feel comfortable sharing that, but, and then I give them a different answer. And when I do, you know, workshops on how to share your story without re-traumatizing yourself, one of the things that I say quite often is that they have not earned that from you. They want this from you, but there's no guarantee that that is safe. And if any part of you is caught up or frozen, or you find yourself having a response, you don't owe them that information. And many times, especially in the media, maybe not as much so in the workplace, but especially in the media, you know, they want those headlines, they want those feel goods, they want the things that they know are going to elicit dopamine and serotonin in people's brains, even if it comes at a cost to the person giving it. Good stuff going on in the chat here. From Alex, I think it's important to remember that white supremacist culture has played an enormous role in compartmentalizing, isolating, and oppressing everyone. When we can understand how and where we each hold power and privilege, we can create more space for everyone and all. I love that, and that is a whole conversation all on its own. But I would agree with you on that as you know, the function of removing culture from something by using, you know, like if I pay for it, I get to have it. And if you, now it's mine, now that I have paid for it, now that I've asked for it, and you can't tell me that it isn't mine, right? That because I bought it, it's mine. There are pieces of that that are at play within that framework for people who are doing media work within stigma. So I would definitely not disagree with that. But man, that is a whole other presentation for another day. But yes, and I love the comment, yes, of intersectionality. Those are important things too. Again, I have to do another conversation on that one. I'll be putting my email in the chat at the end here, and then we can most definitely have even more bigger conversations around that. So again, not sensationalizing. We don't want to describe people in recovery as superhuman or overcoming these horrible feats and conditions. We want to be thoughtful and accurate, right? Because I don't know about you guys, but how many of you, you know, in early recovery saw that one person that just seemed to like completely embody everything that recovery is, right? Like right on the surface. And they, you kind of had them on a little bit of a pedestal, and it was difficult to approach them, and it was scary and it was intimidating, right? We don't want recovery to be something that is scary and intimidating, because we don't want anybody who is contemplating this to see an article or see an expectation within a workplace and become demoralized and immediately feel defeated, right? We want it to be something that is inviting. We want it to be something that seems practical. And we don't want to use substance use related terms like addicted to power, in recovery from that job, or had a relapse on chocolate ice cream, right? Or, you know, we've seen this in other areas too, where somebody was like, oh my God, that was like just so traumatic, even though was it traumatic, or were your feelings hurt? Like there's a difference there. You know, was somebody toxic, or were they having a bad day? Or are you having toxic feelings, or are you just, you know, working through some anger right now that is justified for the situation that you're in, right? How we talk about these things changes how we think about them. And then how we think about things changes the way that we act upon them. And that's really what we want to do, is we want to change the way that this is acted on. So we don't want to like minimize the struggles of addiction either, which is when we use those metaphors, it like shrinks it down. There's this delicate balance between normalizing needing services and support, and then also shrinking it down so small that people are just like, well, what is your problem? You should just be able to do it. I quit eating ice cream. You should be able to stop doing meth, right? Because those things are exactly the same, right? So especially when we're doing this in media at large, I know that, you know, between each other and ourselves, it's kind of funny because the humor is more like, it's so ridiculous that I said this that we're gonna laugh, but when we're having people that don't have any context, they don't have that context, so it changes the way that they think about it to be more literal as opposed to you know, tongue-in-cheek humor. All right, I have a question in the chat here. You mentioned the term normies. One thing that I practice in my recovery language is not using terms, however cute they are, referring to people without an addiction history as better than or normal, or somehow the goal everyone has, and everyone, I'm so sorry, the goal that everyone has challenges. We in recovery just tend to be more forthcoming and open with a challenge that we have and are facing. Also, halfway house ick. Yes, yes. Sober living is probably a better term for that. And I would challenge that even a little bit. I think there are plenty of people who are forthcoming with their challenges. They're simply just not the same as ours. So we maybe don't see it as honest enough, right? Because we all project ourselves on other people. And I would agree that I don't like using those other terms as well, because we don't necessarily want to return to normal, you know, saying that substance use disorder is abnormal. Oh, when they refer to kiddos. Yeah. Absolutely. All right. Where are we at for time? Getting a little lost. Okay. So we have a little bit of time now for some discussion, some thoughtful pieces. Again, here is my just my little chart. And now that we have gone over some other parts of both the in the media and within the workplaces versus individual stuff, this is just a handy dandy little language chart for the recovery dialects. So things that we want to do in mutual aid meetings, like Rennie was talking about earlier, right? When you have to be in all these different settings, when you're in all these different settings, you might be moving back and forth. we want to definitely just stop using the term altogether, substance abuser. Like if there's nothing else that you take away from this, it's just stop using the word abuse. Just stop it. That one, and when you hear others using that one, just simply reiterate the language back to them. That word abuse does so much for stigma, maybe even more so than addict or alcoholic, because when we think about somebody who is abuser, if there is an abuse, that means there is a victim. That means somebody has been harmed. So if somebody is a substance abuser, we have to immediately think they have caused harm when all that they've done is existed in this world as somebody who has a substance use disorder. Yeah, Michael.
Just think of Phil Valentine when he's thinking of abuse. He's like, I never abused my drugs. I took very good care of them.
Yes, exactly. If we can completely eliminate addict and alcoholic from our vocabulary to replace it with, you know, a person with disordered use or disordered drinking, or even just use substance use disorder. We want to remember that, you know, MAT is not necessarily treatment all on its own. It's one pathway, one part of treatment. Things that we really want to replace this with is person with a substance use disorder, alcohol use disorder, person with an opioid use disorder, people in long-term recovery, and have had pharmacotherapy, right? As opposed to just this switching medications, just because of the stigma around, you know, like switching one drug for another, right? We want to be able to get people whatever it is that helps them to move on their recovery pathway. Okay. All right, so I'm going to stop the screen share here so that I can look at you while we're talking. All right, so thoughts, questions, comments, story time. What have we got? Oh, what is a replacement option for relapse? Reoccurrence of use, or returned to disordered use, or even just returned to use, because we don't necessarily know that it was disordered or chaotic, right? I'm going to put my
How
email
about
in the
just
chat for you.
using an old coping strategy?
Yeah, that's another one too. Or familiar
Familiar
coping strategies. Other thoughts? I know it was less interactive today. We didn't do as much small group, but whew, we had a lot to get through.
One thing when you talked about pictures in the media, one thing we don't think too much about is when we're talking, discussing with people about going into treatment, and we show them the pictures of the treatment center. If it's in a clinical setting, you know, you got all the warning signs on the outside of the door. You go in and you've got clinical furniture, you know. That's one thing that puts people off also.
Absolutely.
So getting our systems to think about, you know, just changing the atmosphere. You don't need all the warning signs on the outside. You know, a more home atmosphere on the floor, you know, in the common areas. It makes a huge difference. Also changing sometimes the way they do treatment. We had a treatment facility here. I couldn't believe they did this. The person had been detoxed for 7 days already. So medically they were cleared. She got in there. They just handed her the envelope and said, here are your rights. I just looked at her and I went, are you forgetting something? And she went, what? And I said, you're supposed to read these to her. You know, well, you know, not everybody that comes in can understand. I said, that's beside the point. You give them the brochure so that later, if they are, you know, when their thinking does clear, they have it for reference. then I left her and I got home. 5 minutes after I got home, she called me and she says, they put me on phenobarb. I says, what? Yeah, they were afraid I might have, but yet they wanted her to go through they put her through a 28-day program on phenobarb. The whole time she was on phenobarb. You can't retain anything when you're on phenobarb.
Mm-hmm. Yeah,
Why
definitely the way we do things can use some improvements for sure. Yeah, that is it is difficult when that autonomy and that dignity isn't included in the practices. And one of the ways to start doing that is to change the way that we talk about it. Definitely. Other thoughts, questions, challenges. I love challenges. I love a good debate.
Hey, Patty.
Yeah.
I didn't I think I didn't see the screen share for the second half of today. Can you share that chart, that last chart that you had, like in email, if I emailed you?
Yeah, I definitely could do that. Yeah, it is. It's a nice little one to just print up just to have it for people.
Yeah.
Will you be sending out the slides?
So these sessions are recorded and they will be on the CCAR's website, so you should be able to access it anytime. So I'm just not going to send out the slides specifically, but you'll still be able to get them.
Patty?
Yes.
I loved when you talked about the re-traumatization of the story and how so I'm actually taking another class at 12 o'clock about for trauma-informed coaches. And it's interesting for me, the recognition that usage answered a question or filled something. Until I knew better, I couldn't do better. So I love the idea of you talking about, was it a hard feeling or was it traumatic, and how the relationship of that language. I appreciated that.
Awesome. Thanks. Yeah, I never know what's going to stick with people until you tell me. And then I'll be like, more? Would you like more? I don't know if you've noticed, but I can talk a lot. All right. Well, hearing none, I'm going to say thank you so much today for your very active participation. You guys were a great group. I love the discussion. I did put my email in the chat. You can also find me through our website, heliosrecoveryservices.com. And I do have some other webinars that will be coming up here with CCAR. I think the dates will be rolling out pretty soon, so keep an eye for that. And thank you so much. I'm so glad when I get to have conversations with people all over the place. So have a good one, and I'm going to jump off.